Good morning to all. Today's topic is on spirochetes. So what are the topics covered under this? The general characteristics and classifications of spirochetes, the morphology, cultivation, antigenic structure, pathogenicity, laboratory diagnosis, epidemiology, immunity, and treatment. So what are all the general characteristics of spirochetes? What does spirochete mean? Spirea means coil, chete means hair. These spirochetes are large, motile, flexible, slender and helical organisms. These are motile with the presence of an endoflagella. The size of these organisms range somewhere between 5 microns to 500 microns in size, and when you see the Gram's reaction, all these are gram negative in nature. Most of these spirochetes are free living saprophytes or they are obligate parasites. These are all aerobic, anaerobic or facultative anaerobes like any other gram-negative bacteria. The type of motility which is exhibited by these spirochetes are described as corkscrew motility, or if you see in case of treponemes, these are having lashing motility. These spirochetes are classified into two different classes. One is Spirochetaceae, the other is Leptospiraceae. Spirochetaceae, the genera, it has different families like Spirocheta, Treponema and Borrelia. Whereas Leptospiraceae, they have two genera, that is Leptospira and Leptonema. Most of these spirochetes, like I already said, are all saprophytes, that is, they are free-living saprophytes, except for Treponema, Borrelia, and Leptospira. If you see the structure of these spirochetes, they are all having an outer membrane, periplasmic space, peptidoglycan, and inner cytoplasmic membrane, like any other gram-negative bacteria. And they have, the other bacteria, they have an exoflagellum, whereas these have endoflagellum. Coming to the pathogenic spirochetes, the most important one is the Treponema. Trepos means turn, nema means thread. These are short, slender, with fine spirals and pointed or rounded edges. The number of spirals in the treponeme range somewhere between 6 to 12 in number. The wavelength, that is between the two spirals, is about 1 micron in size, and the number of flagellae which are present in the treponemes are 3 to 4 in number with on both the ends. Most of these treponemes are pathogenic, or they are commensals in the mouth, intestine and genitalia. The pathogenic species of treponeme are Treponema pallidum, which causes syphilis, Treponema peritinae, which causes yaws, endemic syphilis, which is caused by Treponema endemicum, yaws, which is caused by Treponema peritinae, and pinta, which is caused by Treponema keratium. Now coming to Treponema pallidum, this was discovered first by Chardin and Hoffman. The size of these Treponema pallidum, they are about 4 to 14 microns in size. The morphology and the motility can be best made out under the dark ground microscopy or the phase contrast microscope, and you can use certain stains to stain this. Sometimes we use Giemsa staining, wherein you have a rose red color, but most common method which is used for staining these treponemal or the Spirochetaceae group of organisms is by silver impregnation methods. The silver impregnation, when you do on the secretions or films, these are called as Fontanas stains. When you do it on the tissue sections, it is called as Levidity's method. So this is how it looks like when you do the Fontana's silver impregnation staining, where you can see yellow background with brown colored treponemas. This is the ultrastructure of Treponema pallidum. Now coming to the cultivation of these organisms, the pathogenic treponemes, they cannot be cultivated or grown in an artificial medium. Most of these strains are maintained in animals wherein you subculture in susceptible animals like that of the rabbit testis. The pathogenic strain is called as Nichols strain, which is a virulent strain of Treponema pallidum, and this was first isolated from a case of syphilis in 1912, and since then has been maintained in the rabbit testis for decades. The non-pathogenic strains of the Treponema, these are Ritter strain and Noguchi strain. These can be maintained in artificial media under the anaerobic conditions. Most often used media is the thioglycolate media containing serum. It is also seen that these virulent strains can also be grown in tissue cultures of rabbit epithelial cells. Resistance. These are all delicate, inactivated by drying or by heat, and in fact they are susceptible to, because of their susceptibility to heat, these were in fact used for fever therapy for syphilis. That is, the patients who are suffering from syphilis were also put along with patients who are having malaria, wherein you know that in malaria these people present to you with high degree temperature, and therefore it was used for killing the treponema because they would get malaria, and then it was easy to treat malaria, and then the syphilis would come, the temperature would come down in syphilis. These are also inactivated when it comes in contact with oxygen, distilled water, mercurials, bismuths, common antiseptic agents, and antibiotics. Coming to the antigenic structure of these treponemes, they are induced or they induce three different types of antibodies. One is group specific antigen, other one is a reagin antibody, and the third one is polysaccharide or species specific antibody. The reagin antibody, this reacts with tests for syphilis such as Wassermann's, Kahn, and VDRL, in which a hapten extracted from beef heart is used as an antigen. This lipid hapten is known as cardiolipid. Group antigen is found in Treponema pallidum as well as the non-pathogenic treponemes. Species-specific antigen is a polysaccharide antigen antibody in nature. The antibodies can be tested by specific Treponema pallidum antigen. So these Treponema pallidum, as I already said, causes a sexually transmitted disease which is called as syphilis. Venereal syphilis is usually occurs due to sexual contact. The spirochetes enter through minute aberrations on the mucosa or the skin. The infectivity to the sexual partner occurs most commonly during the first 2 years of the disease, that is, in the primary, secondary or early latent stages of the disease. The infective dose is very small, as low as 60 treponemes are capable of infecting human volunteers. They multiply at the site of entry and the generation time is around 30 to 33 hours. There are 3 stages of syphilis. If you see the pathogenicity of it, as I already said, syphilis can be acquired by sexual contact or by vertical transmission, that is from mother to the fetus, or by blood transfusion. Spirochetes enter through minute aberrations on the mucosa, and as I already said, the infective dose is as low as 60 treponemes. They multiply at the site of entry. The incubation period ranges somewhere between 10 to 90 days, on an average 30 days. They start with the clinical manifestations. The first stage is called as a primary lesion. The primary lesion is a hard chancre. This begins as a single painless papule. The common sites where it can occur: in males, it is the penis; females, cervix and labia; homosexuals, anal, rectum or the mouth areas. This papule rapidly ulcerates. The chancre gets covered with a thick exudate which is rich in spirochetes. The regional lymph nodes, they get enlarged, they become discrete, rubbery and non-tender in nature. The chancre heals by about 10 to 14 days. This is how a hard chancre appears. Once the chancre heals, the secondary syphilis sets in, which is mainly due to the widespread and multiplication of spirochetes and dissemination of these spirochetes through the blood. This takes about 1 to 3 months after the primary lesion has healed. So what are all the lesions wherein you can get during the secondary syphilis? You see roseolar skin rashes, which occurs mostly on the palms and soles; condylomata at mucocutaneous junctions, which are mucocutaneous papules which coalesce; mucus patches in the oropharynx; ophthalmic lesions; osseous or bony lesions; and meningeal lesions. The roseolar skin lesions, condylomata and mucus patches in the oropharynx are the characteristic lesions which occur during the secondary syphilis. These usually undergo spontaneous healing in about 4 to 5 years of time. So these are some of the pictures which show you the macular lesions which can appear in the tongue, submucosal layers on the palms and skin. The secondary syphilis then leads, after 4 to 5 years, into what we call as a latent syphilis. This latent syphilis, usually there are absence of any clinical manifestations, and the diagnosis is most often by serological tests. Outcome of this latent syphilis, it usually is most common way it takes is persistence for lifelong infection, or it can develop into a latent infection, which is a rare one, and it can also undergo spontaneous cure. After several years of this latent syphilis, it can land up into tertiary syphilis. In tertiary syphilis, they contain very few spirochetes. Manifestations are usually due to delayed hypersensitivity. The lesions which you will get during the tertiary syphilis is cardiovascular lesions, the most common being the aneurysms, chronic granulomata, which is called as gamma, meningovascular manifestations, wherein it has vasculitis which lead to stroke. Few of these tertiary syphilis cases can lead into late tertiary or quaternary syphilis, wherein the manifestation are neurological, example, tabes dorsalis, general paralysis of insane, wherein the onset of psychotic symptoms occur, wherein there is loss of interest in work, memory lapses, etc. Tabes dorsalis is progressive ataxia which leads to pain sensation, loss of pain sensation and loss of peripheral reflexes due to demyelination of posterior column. These are some of the pictures of the latent syphilis, wherein you have neurosyphilis and gamma formation. The non-venereal syphilis usually occurs in occupational situations, like for example the doctors or the nurses, wherein it could be due to contact. Because when you touch the lesions, you may have chances that if there is any aberrations on the skin, these can enter through, and usually they have the lesion on the fingers. It can also be transmitted by blood transfusion. In situations when the syphilis has got through blood transfusion, you will not have any primary chancre forming. The third non-venereal method or mode of transmission is transplacental transmission, which can occur during any stage of pregnancy. Women with early syphilis can infect her fetus more commonly, that is about 75 to 90%, when the syphilis duration is over 2 years. Early syphilis, it's 75 to 90, and if it is beyond 2 years, it is about 35% chances or risk of the child getting the infections. Lesions, when you see in the congenital syphilis, they develop somewhere between the 4th month of gestation when the fetal immune competence starts appearing. This suggests that the pathogenesis of these treponemes, they require immune response from the fetus. So early manifestations of this congenital syphilis, they have rhinitis, which are called as sniffles, mucocutaneous lesions, bone changes, hepatosplenomegaly, lymphadenopathy. The late manifestations, that is after 2 years, these are characterized by interstitial keratitis, 8th nerve deafness, bilateral knee effusions, which are called as Clutton's joints, and these can have residual stigma like saber shin, Hutchinson's teeth, wherein you have notched central incisors, mulberry molars, and saddle nose. So these are this picture which shows you various symptoms of congenital syphilis. So coming to the laboratory diagnosis of syphilis, the first and foremost thing which we can do is the microscopic examination. Dark ground microscopy, low sensitivity, at least you require a concentration of 10 raised to 4 per ml of organisms in the exudate for it to be around 80% sensitive, and you require multiple samples to be examined. So collection of the sample for this dark ground microscopy usually applicable in the primary and secondary stages of the disease, and in case of congenital syphilis with superficial lesions. The lesions are cleared with a gauze which is soaked in warm saline, and the margins are gently scraped. Gentle pressure can be applied to the base of the lesion, and the serum that exudates is collected. Wet films are prepared, examined under the dark ground microscopy. So the type of bacilli which you see when you do the dark ground microscopy is, you will have slender, flexible, spirally coiled bacilli with tapering ends, and the type of motility is the extension, flexion and extension, and corkscrew motility. The second one which we can use is the direct fluorescent antibody staining test. Here, the smear of the exudate, which is fixed with acetone, can be stained with the fluorescent labeled monoclonal antibody against the Treponema pallidum surface antigen. When the slide is put under the fluorescent microscope, you can see apple green fluorescent bacilli. Sensitivity is about 100%. When fresh lesion exudate is examined, you will have 100% sensitivity. Silver impregnation techniques can also be used. That is, the principle behind this is to thicken the size of the bacilli. So when you use the silver impregnation technique, the silver nitrate that gets deposited on the surface of the bacilli, it makes them appear thick. So therefore, the lividity stain is used when you stain the tissue sections, and Fontana's stain is used for staining the smears from the exudate. Now coming to the serological investigations of syphilis, you have non-specific tests, group-specific tests, and specific tests using pathogenic treponemes. The non-specific test or the reagin antibody test, which uses the cardiolipin antigen, are called as standard tests for syphilis. Group-specific tests, these tests we use the cultivable treponemes, that is the non-pathogenic strains of treponema, which are called as Reiter's strain antigen. Specific tests which normally we use is the pathogenic treponemes, that is Treponema pallidum. So there are different standard tests which are used for detecting these treponemal antigens or the antibodies. The non-specific tests using the cardiolipin antigen, these are the Wassermann's complement fixation reactions, Kahn's flocculation tests, which are not used anymore. They are all obsolete techniques. Most commonly one which we use is the VDRL and rapid plasma reagin tests. VDRL ELISA test also is being used nowadays. When we are performing the group-specific tests using the cultivable treponemes, the test which we do is the Reiter protein complement fixation test, which nowadays commonly it is not being done. The specific test which we do using the pathogenic treponemes is Treponema pallidum immobilization test, fluorescent treponemal antibody absorption test, Treponema pallidum hemagglutination assays, and Treponema pallidum enzyme immunoassays. So as I said, these Wassermann's fixation tests or the Kahn's test, nowadays we are not using these tests in the labs. Most often what we are using is the RPR and the VDRL. So this cardiolipin is the cardiolipin is a purified lipid extract of beef heart. Along with which we add lecithin and cholesterol to perform the VDRL test. And this cardiolipin is chemically diphosphatidylglycerol glycerol in nature. Coming to the VDRL test, the VDRL stands for Venereal Disease Research Lab. This was the place where it was first developed, and this is the most commonly used test. So the method to do this test is the patient's serum, patient's blood is drawn, the serum is separated out, inactivated by heating it at 56 degrees Celsius for 30 minutes. This method is done to remove the non-specific inhibitors. 50 microliters of the serum sample is taken and 1 drop of VDRL antigen is placed on the VDRL slide, and this slide is placed on a rotator which rotates at 180 RPM per minute for 4 minutes. This is then examined under the low power microscope. If you see clumps, it is called as reactive. If there are no clumps, if they are uniformly distributed crystals are seen on the microscopy, this is a negative or a non-reactive test. This is only a qualitative test where you can say it is positive, negative. If the clumps are there, it is positive. If the clumps are not there, it is negative. The disadvantage of using the VDRL test is, or the RPR test, most often what we see is the biological false positive reaction. As cardiolipin antigen is present both in Treponema pallidum as well as in the mammalian tissues, these antibodies may be induced by treponemal or a host tissue antigen, which accounts for biological false positives. The BFP is defined as a positive reaction obtained in cardiolipin tests with negative results in a specific treponemal test in absence of past or present treponemal infections and not by technical faults. So when do you call it as a biological false positive? Whenever you have a positive test by cardiolipin and a negative test by a specific treponemal antibody test. So where all can you see this biological false positive reactions? So these can be seen in leprosy, malaria, relapsing fever, infectious mononucleosis, hepatitis, and tropical eosinophilia, to name a few. You can also have a physiological condition where you can have a false positive. That is your pregnancy. During pregnancy, you may have false positive reactions. Group specific retest tests can be used, but nowadays we are not doing the complement fixation tests. The confirmatory test we do by the specific Treponema pallidum test, wherein we use the virulent Nicholas strain. So you have Treponema pallidum immobilization test, where the test serum is incubated with the complement and Treponema pallidum is maintained in a complex medium anaerobically. If antibodies are present, the treponemes will get immobilized when examined under the dark ground microscopy. The fluorescent treponemal antibody test. This is an indirect immunofluorescence test wherein we are using smears prepared with Nicholas strain. Add the patient's serum which contains the antibody. If the homologous antibody is present, then you can see the fluorescence when you see it under the fluorescent microscope. The FDA absorption test. Here the test serum is pre-absorbed with sonicate of Rita's treponemal strain to eliminate the group specific reactions. Then this is accepted as a standard reference test. So this is how FDA ABS will look like. You can see the spiral antigens present in fluorescent green. The TPHA, Treponema-Pallidum hemagglutination test. This uses stand erythrocytes with sonicated extract of Treponema-Pallidum as an antigen. The test sera for TPHA are absorbed with a diluent containing the component of Rita strain. The sera screened at initial dilutions of 1 in 80, but titers of 5,120 or more, which is usually common in the secondary phase of the disease. The TPHA is as specific as FTABS, almost sensitivity except in the primary stages. These advantages have made TPHA a standard confirmatory test. So when you see all the serological tests, the frequency of the antibodies being detected in the various serological tests are as such. In primary phase of the disease or primary stage of the disease, the most 100% you can be sure you can get it by FTABS, you can pick up the antibodies. The secondary phase of the disease, almost all the tests will pick up the antibodies. The latent or the late you have to do FDA, ABS and TPHA, which have a higher sensitivity of picking up the antibodies when compared to the VDRL or RPR. So when you see the immunity for these, antibody-mediated immunity, not very effective. Cell-mediated immunity, the T cells and the macrophages are the prominent in early phase of the syphilitic lesions. And most often you have the sensitized Th1 cells which secrete the cytokines which favor the clearance of spirochetes by activated macrophages. Coming to the treatment of the disease, a single injection of 2.4 million units of benzathine penicillin is good enough to treat the cases in early stages of the disease. For latent syphilis, the same 2.4 million units is repeated weekly for 3 weeks. Patients who are allergic to penicillin, doxycycline can be used. Ceftriaxone is also an effective drug, especially when it comes to neurosyphilis. The penicillin treatment sometimes can induce adverse reactions like fever, malaise, exacerbation of symptoms, wherein this may be due to liberation of toxic products like tumor necrosis factor from the destruction of the treponemes or due to hypersensitivity. So it's usually, even if you have these reactions during the primary and secondary stage of the disease, with just bed rest and aspirin, it can take care of these lesions, but it can be dangerous when there is the latent syphilis. So the rest of the non-venereal treponemes will be taken by Dr. Uma, and the other diseases like Pinta, Yaws, Borrelia, Leptospira, all those will be taken by Dr. Uma.